Yesterday's video, for some reason the audio did not upload. I think it was a rendering issue. I think I've temporarily fixed it for today. Hopefully you're hearing me loud and clear. I had a patient who actually attended today, and I was really keen to get this video uploaded tonight. Attended with bilateral fully occluding dry earwax. The patient also has otitis externa of both ear canals. Otitis externa is an umbrella term for an infection or inflammation of the outer ear canal and the outer layer of the eardrum. So we're just performing the procedure on the left ear first. The patient felt this ear was the worst out of the two, and I'm just using a Zollner suction probe to tease out this very dry, crumbly wax. You can see the patient has got otitis externa, some eczema of the lateral part of the ear canal, so it's some very dry, flaky skin. Thus far, the Zollner suction probe is very effective. We're just beyond the second bend now of the ear canal, and I know it's a second bend because it's the bony part of the ear canal and there's no hair follicles, there's no cilia on this part of the ear canal. In addition, there's a narrowing called the isthmus, so we all have two narrowings. The first narrowing is roughly 1 centimetre into the ear canal, and that's where the bony part of the ear canal meets the cartilage portion of the ear canal. And the second narrowing is approximately 0.5 centimetre away from the eardrum. So the ear canal narrows and widens, and it narrows and widens again. And this remaining plug of dead skin and wax is lodged within the second isthmus. There's a lot of dry skin adhered to the canal wall, which is also attaching to the earwax. Dead skin in the ear acts like a double-sided sticky tape. It sticks to the ear canal wall and it also sticks to the earwax, and sometimes it can be very difficult to elevate and retract the dead keratin skin both off the ear canal and also the earwax. So I'm just on the posterior canal wall, so the back part of the ear canal. You can see that layer of skin that I'm trying to peel off the canal wall. We have to be very gentle in this region of the ear canal. The outer third of the ear canal is made up of cartilage. So it's the outer third, and the cartilage has a thick layer of skin that, well, thick relatively compared to the thickness of the skin that lines the bony part of the ear canal. So the skin that lines the cartilage portion of the ear canal is roughly 1 millimetre in thickness. There is also some muscle underneath the skin and some fatty tissue. The inner 2/3 of the ear canal is made up of bone, and there's just a very thin layer of skin measuring 0.1 millimetre, so 1/10 of the thickness of the skin that bears the outer part of the ear canal. So it's very delicate. If we make contact with the bony part of the ear canal, the patient won't be happy. Apologies for not editing this black screen out. Must have been one that I missed. The patient's ear canal is also slightly narrow, which makes it a bit more difficult to manoeuvre the instrument once you're in the ear. So when we're trying to remove skin or even wax, any region of the ear canal actually, we need some manoeuvrability of the instrument. Remember, the ear canal itself, the diameter of the average ear canal is approximately between 0.7 and 0.9 millimetres. So you can almost compare it to, well, similar to your little finger, or say even smaller than your little finger. And then you've got two bends, and there's a narrowing and opening, and then a second narrowing and opening. So it's a very difficult orifice to operate in sometimes in some people's ears. See, we're making very good progress now. I think this is the final plug of wax and keratin. You also can tell that the wax and keratin's been there for a while because it's oxidized. Fresh earwax is usually a light brown shade. Fresh dead skin is actually white, and over time the dead skin and wax oxidizes and it turns into a darker shade of brown, and eventually it can also turn into a completely black shade, a completely black appearance. And you know, if it's black, it's been there for a long time. So I've managed to extract this plug of wax out of the second narrowing, the second isthmus, which is around 0.5 centimetre away from the eardrum. But there is still, it's a bit tricky extracting this from the first bend. So I'm going to bring this forwards, and you can see this is the first narrowing the first isthmus, and it's getting trapped here. Really having to pull it through, extract it through. I was reluctant to put any drops in just to help, because the patient had been using drops quite a lot. Not sure how well they've been using the drops because the wax is still relatively quite dry. There were some parts of the wax, more lateral, so near the entrance, that was a bit more wet. That had soaked and absorbed the drops. I'm just trying to rotate this wax upwards, so I must roll it up and then roll it back down. Trying to squeeze it through, tease it through the second, well, sorry, not the second narrowing, the first narrowing. You can see I'm going to the top of the plug of wax and trying to bring it down and just trying to wriggle. So I've just decided to use some forceps now. Just trying to get the jaws of the forceps either side. Managed to remove a little bit there. There's nothing more for me to grab onto now, so I'm going to have to go back in with the Zollner suction probe. Can't use a hook or a Jobson horn at that stage because there was no opening. To use an ear hook or a Jobson horn, correct, you need an opening to get in and behind the wax. There's nothing there available. Nonetheless, managed to remove it using suction. Just going to have a look inside the ear. I think there's some dry skin at the roof of the ear canal, but eardrum's an amazing view of the eardrum. That's what's so great about an endoscope. The endoscope, it provides an unparalleled view of the whole ear canal and also eardrum. It's a panoramic view. For years as an audiologist, I used to use an otoscope, and an otoscope, I've still got my original otoscope I bought many years ago after I qualified, spent a lot of money on it. Haven't used it in around 5 or 6 years because I would never go back to an otoscope. The view, I would have to make an effort to try and capture the view of an otoscope